Good afternoon, everyone. We welcome you to the second plenary for the day, Driving Change for a Resilient Future, Climate, Health, and Nutrition. The interconnected challenges of climate change, health, and nutrition are among the most pressing issues of our time. As global temperatures rise, the impacts on human health and food systems become increasingly evident, threatening the well-being of millions. Climate change exacerbates malnutrition by disrupting agricultural systems, reducing food security, and compromising the quality of essential nutrients. Simultaneously, it intensifies health vulnerabilities through heat waves, vector-borne diseases, and extreme weather events, proportionately affecting the most marginalized communities. This is a good opportunity to deliberate on this topic of priority for everyone. Let's invite the chair for the plenary, Dr. Vikas K. Desai, Public Health Expert and Technical Director, UHC RCE Surat, and Dr. R. Bakshi, former Professor, Community Medicine and Subject Expert.
Dr. Vikas Desai, a public health expert with over 5 decades of experience, specializes in urban health, climate and health, and community nutrition. She holds an MD in community medicine and is an MSc in applied nutrition, with fellowships from UNICEF and UK institutions. As honorary technical contributed to global health policies. Dr. Desai is also an advocate for societal change, leading women's cooperatives and influencing urban resilience strategies.
Dr. R. Bakshi, former Professor, Community Medicine and Subject Expert, is an experienced professor with a demonstrated history of working in the hospital and healthcare industry. He is skilled in epidemiology, prevention, health promotion, global health, and healthcare management. He has a strong education professional with a DCH, MD focused in pediatrics, adolescent health, preventive and social medicine from Maharaja Sayaji Rao University of Baroda, Gujarat, India. He has a research experience with ICMR, Government of India, University of North Carolina, and University of South Florida, USA. We welcome you, sir and ma'am. I would now request the speakers of the plenary, Dr. Raj Shankar Ghosh, Senior Advisor, Center for Environmental Health, PHFI, Professor Monica Arora, Vice President, Research and Health Promotion Division, PHFI, Dr. Jay Shah, Associate Professor, Emory University School of Medicine, Dr. Harsh Bakshi, Team Lead, SHSRC, Gujarat, and Dr. Shalu Chaudhary, Assistant Professor, IIPHE on dais. Give a loud round of applause to our speakers. We hand over the stage to the esteemed chairs to introduce the speakers of the plenary and take the plenary forward.
Good afternoon. I'm very pleased and thankful to IIPH, Gandhinagar, to begin with, for this wonderful conference plenary. And now, getting back to the job, I'm pleased to introduce the first speaker of the session, Dr. Raj Shankar Ghosh. He is an advisor of environmental health of PHFI, and he has 30 years of experience, and he has worked with West Bengal, PATH, One World Health, Bill and Melinda Gates Foundation, and he is the recipient of the Fellowship of the Indian Public Health Association, and currently he is an independent consultant for climate and health in India, South Asia, and Africa. Leads the Center for Environmental Health at the Public Health Foundation of India, and he is the founding member of Quality, Equity, and Inclusiveness in Public Health initiative at the Department of Management Studies in IIT Delhi. Professor Rajsekhar, please.
Thank you very much, sir. So good afternoon, everyone. I will be speaking on building climate resilient health systems in India, the role of non-governmental organizations. I'm representing Public Health Foundation of India, the Center for Environmental Health. Though we are strictly not a non-governmental organization, we are more an academic institution, but we have a lot of programs which we work on in the non-government sector. So by virtue of that, I'll be relating some of those experiences. So what we will speak on, first few slides would be on the concept of climate resilience. Then I will speak a little bit about the Health Environment Leadership Platform, which Public Health Foundation of India supports, a network of hospitals across India working towards climate resilient health systems. And finally, I will leave you with a few slides of imagination. So to begin with, on the concept of climate resilient health systems, we all know that there are 4D outcomes of climate change on human health broadly. The first is around the disasters that happen, the natural disasters, and the outcome of the disasters. The second is around the diseases, the chronic diseases, acute diseases occurring in all the spectrum of age group and particularly affecting the various kinds of vulnerable sections of the society. The third is the displacement of the populations that happens because of the disasters and the diseases, and the disruption of the livelihoods of the social fabric that happens because of climate change. All of this is encased in another D, which is the disproportionately affected populations across the society, particularly the vulnerable populations. So coming back to what is a climate resilient health system, we know that a climate resilient health system is one that is capable to anticipate, respond to, cope with, recover from, and adapt to climate-related shocks and stress so as to bring sustained improvements in population health despite an unstable climate. This is the World Health Organization's conceptual definition of climate resilient health. What does it do? It works across a cycle of what we call the P factors, the prediction of the disasters, the diseases, the displacements that might happen, the disruptions in our social fabric, in the livelihoods. The second is, if we have predicted, be prepared for what is going to come, and then prevent as much as we can. Once it happens, protect the population from the various kinds of outcomes, and finally progress towards the next steps in terms of life. There are various health system blocks, and there are 6 blocks which have been identified by the World Health Organization, which are the health systems block, independent blocks that must become climate resilient. It is about governance and leadership. It is about the healthcare workforce. It is about the health management information system, essential medicines, drugs, diagnostics, service delivery, and financing. However, there are various drivers of health system, and in today's world we call them the 6I drivers. The integrated health system delivery, of which we have heard before, impact assessment at every step in order to prioritize our resources, innovations, both technological and programmatic, infrastructure based on which the service will be delivered, institutionalization of the learnings within a framework in the public and the private sector, and finally, the investments that must be made in order to take all of this forward. The next part is about sustainable health systems. The sustainable health system, as we know, is a health system that improves, maintains, or restores health while minimizing the negative impacts on the environment and leveraging opportunities to restore and improve it to the benefit of the health and well-being of current and future generations. There are various avenues, and all of this is available as a public information in the World Health Organization's Sustainable Health System Guidelines, so I'll not go through that now. What I will come to next is how do we apply all of this within our health and environment leadership platform that is a network of non-governmental hospitals in India. So the health network is a network of hospitals, clinics, and establishments providing environment-friendly healthcare services in India. The leadership and staff of the network focus on reducing the environmental footprint of their establishments by committing to build climate-resilient health facilities that are sustainable within existing health systems in India. This was established in 2017 by the Public Health Foundation of India in collaboration with Healthcare Without Harm, which is a global agency and supported by the Global Green and Healthy Hospitals Network of Healthcare Without Harm. There are various objectives, primarily 4 objectives of the health network. One is reducing the environmental footprint and energy burden. The second is around advocating for collaborative evidence-based policymaking. The third is around building capacity of healthcare and allied professionals for delivering sustainable and resilient healthcare. And finally, the community engagement so that they can be a part of the ecosystem. The focus is on the improvement of healthcare sector's environmental performance by efficiently managing the usage of resources such as light, air, and water. The second is focusing on building capacity of manpower, energy-efficient machines, and environment-friendly materials. And finally, by effectively managing clinical, chemical, and electronic waste generated from day-to-day operations. There are various benefits, but primarily the benefits are around the learning, peer-to-peer learning. The second is around the documentation of the evidences based on which further progress can be made and the innovations that happen. So we had asked our health network hospitals what sustainable healthcare means to them. For them, it is very clear. There are 4 E's that are important for them. The first is around the efficiency. Any sustainable healthcare that we talk about must augment efficiency. The second is around promoting equitable healthcare delivery. The third is around making them economically viable so that they can progress in terms of the investments. And finally, the environmental smartness in reducing the carbon footprint and toxic waste management. There are various public health threats that are posed by climate change. How do these hospitals address this? First is by reducing the carbon footprint of the hospital operations. Second is by preparing facilities for climate impacts and helping to build community resilience. And finally, using their trusted voices to educate patients, staff, communities on the connection between environment, climate change, and human health. There are various ways that carbon footprint can be reduced: energy conservation, renewable energy procurement, alternative transportation, waste management, water conservation, sustainable food and beverage strategies, including meat alternatives, and finally the anesthetic gas management. These are the areas where we are working with the health network of hospitals. We say that there are these building blocks which we call the Law 3M&W. Law stands for light, air, water. Light conservation, air management, the flow of the air management, and the water conservation. The use of energy-friendly machines by trained manpower and use of green materials, and finally, the waste management of the waste that is generated from the hospitals. Now I want to leave you with the Imagine part. This is from the UK's Environmental Board. They have defined this dream for all hospitals to achieve within the National Health Survey of UK, and this is how they plan to go to the future. Imagine a time when going to a hospital is seen as a failing of the health and social care system, when most of the care and support you need can be offered at home, when you can get instant medical help online, by phone, or at a local health center, when health inequalities are low and well-being is the key. Imagine a place where the few buildings that support the health system are in tune with the environment. They use almost no carbon and are integrated into the community and with nature. They are inviting for patients and a pleasure to work in. Imagine a world where friends, family, and society help promote healthy living, where we all support the local health and social care system to recycle, reuse, and minimize waste, where we know that delivery of services takes the long-term financial, social, and environmental costs into account. And imagine knowing that we have done our best to improve health and minimize our impact on the environment. Thank you.
Okay, thank you, Dr. Shekhar. And yeah, it is said that health is one of the outcome of climate change, but is most appealing. And that too, health institutions need to be prepared for climate change as well as adverse climate events. And I think this is just a beginning. Sir, only request is, even architect needs to learn about hospital building and design in relation to climate change. And so that institution also needs to be included.
Thank you very much, madam. Absolutely. So there is an association of the engineers, public health engineers, which are also a part of the training and the designing of these hospitals that we have included. Thank you.
Only one of the observation was, this is for Surat. Every city behaves differently in relation to climate. I am talking about Surat because I have that experience. The proportional mortality season-wise for Surat was highest in monsoon, then winter, and then summer. But in hospitals, it was monsoon, summer, and winter. So our hospital designs has lot more to take care of for patient survival. Until that happens, at least hydration by nurses is very important. So every year we take classes for the nurses to ensure that patients are given regular water, reminder for water, so that there is a good hydration and they can withstand this. And the story in government hospitals and the big hospitals are quite different, and the government hospitals need to plan accordingly. That is also important. We cannot have uniform things. Okay, can I now request Jayesha?
Dr. Jai, please let me say a few words.
Thank you.
He is Associate Professor, Emory University School of Medicine, a pediatrician and interventional radiologist practicing at Emory Children's Healthcare Atlanta, the place which I have visited for an entirely different reason. A global health advocate contributing to projects around the world, including India, China, Madagascar, Peru, and Tanzania. Consultant for MSF Telemedicine and co-chair of the Globe Curriculum at Emory School of Medicine. Co-director of Emory Radiology Global Health Track. Additionally, the SIR International Scholar Chair. Former healthcare fellow in US, House Representative. Engaging with HIV and Indian Caucasus. Honorary member of Foro Vanzo, Mexico, and leads RSNA Global Learning Center in Armenia. Well spread out field for him, and here he is. And he has recently joined IIPH with Dr. Deepak and his team. So, Dr. Jayasha, please.
Thank you. Thank you, everyone, for this invitation. So today I'm speaking on rationalizing evidence on climate health through secondary data analysis. And I'll use the study that I did with Dr. Saxena and our team here as a great example why secondary data is so important. So that's the question that everybody asks is, why is secondary data important? I think all of the sexy papers come from primary data and the big grants go towards primary data. But what I like to remind my students, and I like to tell people in all fields, is that somebody's primary data is your secondary data, and people have spent so much time, money, and resources in gathering primary data that so much secondary data is available, and that secondary data can also be used for great conclusions and for great papers. So secondary data is often openly available and inexpensive. Things like the DHS data set, GIS trackers, different countries, WHO, different NGOs offer these data sets, and they're easily downloadable and often easy to place into things like R and Stata. The archival data is also available, which is very important. So you can get yearly data. You can get data for 1999, then 1998, and look at trends. You can get data over regions. And then that comparative data that you can get over regions is important so that you can compare the outcomes of, let's say, pollution or climate change in Asia versus in the US or other countries. And then the last thing I'll say is that many of these data sets have lots of commonalities for novel ideas. So if you have two completely separate data sets, but they're all based on GIS data or satellite data, then when you make maps, you can sort of overlay maps to see geographic distributions, which is something interesting that we did in our study. So why is secondary data important for climate science? So climate science and analysis has generally been retrospective. I know that there's some studies going on here that are primary and prospective with heat and all, but historically they've been generally retrospective. And then the other thing is that climate science tends to have multiple factors interacting. So clinical and community effects, the variables are often in separate data sets, and you'd have to pull them together. So you'd have to combine a data set like the DHS set or the NASA set. And the other thing that's important is that secondary data and silent pressure can shape policy. So do people here know the story of kind of the air quality in Beijing and how that was solved over the last 10 years or so? So the quick story is that in Beijing, there was a big climate crisis, a big pollution crisis. And one thing that happened was that the government of Beijing was telling the locals that it was okay, that it's not that bad, that this pollution exists everywhere. And what the US Embassy did was they just put a publicly available tracker and they just started collecting data. And so then they would publish this data, and they had this data set of what the pollution levels were at the American Embassy. And so eventually the Chinese locals could see that data and use that data to say that, okay, if this is historically what it's been at the American Embassy in Beijing, then it must not be better for us here, locals in Beijing. And eventually it created enough pressure to have the Chinese government change the policy. Similarly, that led to the US embassies putting these pollution trackers on all of their embassies, and these data is publicly available. And so I've just pulled on the right side of the screen the tracker from New Delhi, which is, of course, a 249 AQI, which is very unhealthy. And so part of this pressure campaigns that are happening from the diplomacy side, I think can also happen from the scientific side or from the policy side or from the people in this room, which is another reason why I think that secondary data is an important thing that scientists should focus on. So my case study that I wanted to talk about is this paper that Dr. Saxena, me, Dr. Yas, and Nandan and Paul George, one of my colleagues, published. And it came from IAPH, and we were able to publish it in the Lancet Southeast Asia. And so that's the impact of ambient air pollution and socio-environmental factors on the health of children younger than 5 years in India. And so the data sources that we used were the NFHS 5 survey and the NASA 2.5 data set, both big publicly available data sets, both secondary data, and we did a population-based analysis. The background on this is that, as you know, that air pollution is a major global health concern. PM 2.5 has been linked to respiratory illness and premature deaths, and the WHO guideline for PM 2.5 is 5, whereas the Indian national standard is 40. And even still, the observed median PM 2.5 in India is 63.4, exceeding both standards significantly. The other thing that we know is that children under 5 are especially vulnerable due to their developing respiratory systems. So our primary objective was to assess the relationship between PM 2.5 exposure and respiratory illness in children under 5. And then our secondary objectives were to investigate socioeconomic factors and environmental factors. And then we wanted to provide this comprehensive analysis of air pollution on a national level. So it was retrospective, it was an observational analysis. Again, as I said, those were the two secondary data sets. And then we did this generalized additive models to capture the nonlinear associations, and we controlled for the socioeconomic and environmental factors. And so the findings on the PM 2.5 levels was that, yes, the higher PM 2.5 exposures were observed in rural and poorer households, and Northeast India records the highest levels due to the urbanization and biomass usage. The regional disparities are especially obvious in this map. So this map is the annual PM 2.5 levels in 1 kilometer by 1 kilometer grids. And so by using the NASA data set and the WFHS data set, we were able to put these maps together. And here we can see that it's significantly different across regions. So in the Northeast, the highest levels are likely due to urbanization and biomass burning, where the West, there's lowest exposure, but there was also a smaller sample size. The rural areas consistently face higher exposure than urban areas. If you look at the purple line on the right side, that's the level that's acceptable by the Indian government, and the lower level, the blue level, is the WHO accepted metrics. The key findings of this were that 3.3% of children reported respiratory illness in the past 2 weeks in India. The risk increased with PM 2.5 exposure even below the Indian standard of 40, sort of proving that the Indian standard isn't good enough, and that the nonlinear relationship observed was that the steepest rise in illness was at lower PM 2.5 levels. On the left is the respiratory infection model with the odds ratio on the left side and the annual PM 2.5 on the bottom, and then on the right side is the heat index, the temperature. When we talk about socio-environmental factors, this is sort of an interesting graph from our paper. The key risk factors we noted were low quality housing materials, the use of toxic cooking fuels, biomass and coal, open defecation and lack of improved sanitation, and then wealth index is negatively correlated with PM 2.5 exposure. So socio-environmental factors, some which we believe are natural to us and some that are actually somewhat unique, are truly related in our study. And you can see kind of the negative red, living in poverty, with decreased sanitation is sort of the worst, whereas if you have improved sanitation, it's sort of the best. So what are the policy implications of this? Well, their focused areas are stricter air quality standards and mitigation strategies specifically towards rural and impoverished populations. This type of data helps to form policy, and I know that here the National Clean Air Program has just been launched by the Ministry of Environment, Forest, and Climate Change as a comprehensive initiative, and it's in partnership with many of the ministries. But the goal here is to meet the prescribed annual ambient air quality standards that are within India. And so slowly, hopefully over time, this will help, but knowing that the Indian standards are still not high enough is good to know, which we sort of concluded from this data set. The other thing to know is that the same problems were faced in other regions and other cities. And so Beijing, Seoul, Santiago, Chile, Mexico City are common examples of very high PM 2.5 levels, which had double-digit reductions over short periods of time. So the fact that we learn environmental kind of mitigation factors from these cities is helpful and important, but also from the scientific perspective, we can use those secondary data sets that they have in those cities to sort of trend our data sets in the same vein. In conclusion, my summarized findings are this: that PM 2.5 is a key driver of respiratory illness in Indian children. Addressing air pollution and socio-environmental factors is critical, and the call to action is to improve clean air initiatives and target interventions to reduce preventable deaths under 5 years. The secondary data analysis was key to this, and I keep coming back to secondary data analysis because I think it's a very important data method or a research method. And the India DHS dataset is one of the biggest and best in the world, and it's obviously accessible and easily attainable through IIPHG. The robust and diverse datasets can link variables through multifactorial analysis and invitation, and look forward to further collaborations.
Thank you, Dr. Jai. Besides the pollution for the postgraduates here, one important message has come from him that it is the data extraction and secondary.
Because it has not reached up to Delhi. So it's not Deval.
I'd like to invite our next speaker, Professor Monica Arora, Vice President, Research and Health Promotion Division, PHFI.
To add a few things to it, she is a specialist in health promotion, NCD prevention and control, and NCD Alliance Executive Director of HRIDY Radai, focusing on adolescents and community health, and has published over 200 scientific papers and outcomes have successfully informed national health programs. Working with tobacco control, ending childhood obesity, WHO civil society work.
Approach, nutrition and climate change intertwine under this endemic. So just to quickly put some context, we have talked about climate change, but to bring it back home, India is one of the disaster-prone countries. Also, since 2018, India has consistently ranked among top 10 countries severely affected by disasters. So very clearly highlighting that the climate impact on health and environment would be grave. Also, the earlier speakers did talk about the vulnerable communities, and I would like to highlight how women, children, and people with low socioeconomic status are disproportionately affected by these conditions. Climate change particularly has significant risk to food security, disrupting the food supply chain, increasing food prices, and diminishing food safety as well. And all of this can reverse the progress and development we have achieved. We can go in the reverse direction, back to extreme poverty. And also, it influences the human food through the interconnectedness of the food systems. So as I introduced the syndemic term, it is bringing together of more than two health conditions or social problems in a population. And this is influenced by the social or contextual factors in that population. In 2019, the Lancet Commission identified the global syndemic of obesity, undernutrition, and climate change. So for us in India, this is very appropriate because we are seeing the continued burden of undernutrition, but now we are also seeing the rising challenge of overweight, obesity, and climate change simultaneously. So these are intertwined in a syndemic approach. When we talk about adverse effects of syndemic on human and planetary health, I'm looking at the numbers of 2 billion people, including children. So it's not only a problem for adults, even for children under 5 who are either overweight or obese. Even looking at undernutrition, 820 million people in global south suffer from undernutrition, and food systems produce over 1/3 of the global greenhouse gas emissions, with agriculture and land use responsible for 71% of this total. So we are seeing that this is an interconnected issue influencing each of the burden that we are talking about. So when we put it in a diagram, all of these have common underlying social drivers. So India cannot afford to say that, okay, we will first address the burden of undernutrition and then we will come to address the issue of overnutrition, because that is for affluent population, which is not true anymore. We are very clearly seeing this reversal of social gradients. So all the non-communicable disease risk factors, which are lifestyle related and also caused because of overweight, obesity, are now seen in the urban slums and even are now visible in rural population. So we have to look at the impact of these, which has been seen in developed countries where overweight, obesity is mostly in low socioeconomic population. In India, we will soon be seeing all of this transferring to our rural areas and in poor communities. So all of this would lead to definitely poor health outcomes. There is lack of physical activity with rapid urbanization, unhealthy diets with ultra-processed foods being massively promoted, and lack of food security because of the various climate conditions that are impacting us. Looking at the data, we all are very happy seeing the trends of malnutrition declining, but still we have anemia, which has seen a reversal trend in prevalence, affecting more than 50% of the population. In this day and age where we are having overnutrition, we need to understand how we need to address the issue of undernutrition. So we know where the problem is, but how to tackle it is the big question which currently the governments are wanting to answer through various strategies. Similarly, look at the overnutrition data. Across rural, urban, we can see from NFHS for men and women, there is a rapid increase in overnutrition. So now the question is, if all of this is causing non-communicable diseases, we now know that major portion of our morbidity and mortality in the country and globally is due to non-communicable diseases. And if the current trends continue, no health system would be able to afford that kind of treatment costs. So the healthcare costs to the government and out-of-pocket expenses are humongous for population to continue. Thus, we need to start focusing on prevention rather than treatment for these non-communicable diseases which are a threat to the health system. These are figures from the global burden disease as well as for India. We very clearly see that these numbers are going to rise very rapidly. India is projected to have 4.1% annual growth rate in number of adults with high BMI. And even among children, the high BMI in 2020 is about 6.2%. It will grow by 2035. So as I had earlier started with saying, climate change has an impact on food security. In 2023, over 333 million people in 78 countries faced acute food insecurity, while 2.3 billion suffered from malnutrition, including 650 million who are undernourished. So we urgently need to mitigate through effective strategies this climate's impact on food security and ensure food sustainability, dietary diversity amidst these challenges. There is critical intersection between climate change and nutrition that I earlier alluded to, but there are pathways. So the climate and nutrition outcomes are interconnected through food systems, water systems, social protection, health systems. So we need to start looking at integrating actions. So if we take an example, then it would be diversify food production, shift to healthy diets, reduce food loss and food waste. And all of this nexus of climate nutrition needs to have an accelerated transformative action for co-benefits to be seen when we look at the three issues in totality. And also to say that as a country, when we say that we will first address undernutrition and then overnutrition, we may have some common solutions. So the syndemic approach actually forces us to look at the solutions may be common when we are wanting to address undernutrition and overnutrition in the current climate change scenario. So what are the approaches to improve resilience? We need to promote resilient agriculture. We need to prioritize health in climate policies. Particularly, we are currently under the guidance of Niti Aayog, PHFI has been tasked to prepare a national nutrition strategy from the same lens. How the current agricultural practices, which is providing food in abundance, but why are we still not able to overcome undernutrition? So we need to look at the nutrient density of the crops. And there are many interventions being undertaken on biotechnology, agronomic practices, and biofortification. Similarly, the PDS system, the public ration distribution system, which is essential food grains, we need to look at those practices. We are not being able to provide enough protein in the Indian diets. So subsidized rates, yes, helps in ensuring that the food is affordable, but stabilizing food prices and also critically looking at India's social protection system so that we are able to provide nutritious food through this system. Continuing to talk about building resilient health systems as well in the emerging climate change and pandemics, how we can ensure health systems have better governance, workforce, and financing, which Dr. Raj Shankar Ghosh also talked about. But one component I would like to emphasize on is community engagement, because all of this is possible only when we have the buy-in from the communities. So community engagement and involvement is very crucial, whether it is talking about One Health, where we talk about interconnectedness between human, animal, and ecosystem health. It cannot remain only in academic papers. It has to translate to communities practicing the outcomes of these research that we undertake under One Health. Also, communicating climate change and health for laypersons' understanding. We talk in these conferences amongst ourselves through researchers, but does common person and communities understand? Individuals and communities need to start adopting those practices that mitigate climate change. Healthier eating options that we talked about to reduce the mortality, unhealthy diets, and the burden that they are causing for non-communicable diseases can only be addressed by not only providing information about healthy food, but making it accessible, affordable, and having an enabling environment for people to adopt healthy eating practices. One such initiative undertaken by Public Health Foundation of India through a multi-sectoral and a multi-stakeholder engagement was where 7 ministries got together to review what is the food environment for children in India. And this was particularly from the perspective of reducing the consumption of food which are high in fat, salt, and sugar, also looking at their physical activity patterns and decreasing the screen time so that both overweight, obesity can be addressed through diet and physical activity. And the recommendations have been presented to the Niti Aayog, which will be soon released. But very clearly, it pointed out that children are being bombarded with HFSS, which is the food high in fat, salt, and sugar food products through advertising. Availability in and around school is also of such food. It's not healthy food options which are available in and outside school. And even in terms of the affordability, definitely the unhealthy food options and ultra-processed food have to be taxed extensively to be able to reduce their demand, and many other social behavior change communication strategies to be adopted to improve their food environment. We are also looking at some of the approaches internationally to improve resilience, and we do have examples from India as well, which is promotion of millets through the National Millet Campaign. But in the National Nutrition Strategy, which we are writing with various working groups, all of these examples are being looked at. So to conclude, I would just like to highlight that apart from resilient health systems, we need to have resilient communities and reduce inequities with their participation so that we can address the underlying causes and improve the conditions of the vulnerable populations. So we need to elevate the education, power and status of women and the vulnerable population. They need to be at the center of these debates and solutions. Let's co-create solutions with the community and engage them in these responses. Thank you.
It's mysterious. Climate, health, nutrition, diet, everything. We try to understand it, and we every time come with some new idea, but we are not completing the cycle. And that's where the challenge lies. I believe that I was taught in 74 when I studied nutrition that malnutrition, exploring malnutrition reasons starts from the agriculture practices of the area, distribution of food system in area, and then comes the family. And we are still working on same issues together. We don't talk about, we have started facing the dual burden, and that's what is discussed already. First of all, we need to establish a fact and convince people that nutrition is also health. Unless that is there, some department working for nutrition, some department working for food, some department working for health, will never solve the problem. We will continue to suffer, and that's what is we have seen. New problems will be added, and with climate change, we don't know what problems we are going to face in time to come. But any new advice, like consumption of millets, should go after the crop promotion for the millets. Otherwise, it is only for rich people, not for poor people. Thank you.
Thank you, madam. And just to add and perhaps trying to complete, the Food and Agriculture Organization preamble quotes Mahatma Gandhi and states that as you increase the distance between the food producer and the ultimate consumer, the people who are at a loss are producers and the ultimate consumers. So that is the fundamental problem as part of development we have to deal with. And I'm saying this reading this morning that malnutrition reportedly accepted in Rajya Sabha is 39%. That is undernutrition, accepted in Rajya Sabha by GOI today. So with this as the burden, we need to look at all the many comprehensive solutions to the problem which are very well highlighted by Dr. Monica. And now we go to the next, please.
The next speakers are Dr. Harsh Bakshi and Dr. Shalu Chaudhary for determinants of anemia in Gujarat, findings from anemia profiling study.
Pleasure and a bit difficult task because after leaving Baroda, what all he has been up to, I do not know, but I'll try and find out from the paper given to me. He is a team lead for SHRC. Dr. Harsh Bakshi has been a wonderful student and an assistant professor for us in the Medical College Baroda, and now a Technical Support Institute team lead and faculty at Community Medicine Department, GMERS Medical College, Sola. He is actively engaged in policy and planning, research, healthcare innovations, and various other activities aimed at health system strengthening. And his habit of questioning why, has helped me improve over a period of time. So with that note of thanks, Harsh, please.
Thank you so much, sir. It's a privilege and honor to be introduced by somebody I would say it's a friend, philosopher and guide. So sir had rightly told me that, 1,000 days. That's what he always tells all his speeches. 1,000 days, that's the time you should spend into medical education, because otherwise you'll get rusted. As I took a little more than that, sir, but I think now I've actively kind of gone into transition more into public health policy planning, and it's a request to all those young budding public health specialists. Medical education is definitely a good field. We can definitely make a difference, but also alternative career options and alternative aspects are also equally rewarding. So I think you can see all the stalwarts sitting here as kind of testament to the fact. I think what we are here today is to talk a little about it's a preliminary assessment and findings of the ongoing anemia profiling study. I'll go with come in with the details in the subsequent slides. So what we've done here is a cross-sectional study among adolescent girls and pregnant women in selected geographies of the state. We all know that NFHS has kind of painted a very bad, it's not painted a bad picture, it has shown us the glim picture or the future, I would say, of how the state is performing badly vis-a-vis where the nutrition is concerned. At one hand, we have that Gujarat ranks first, or it has topped consecutively in the SDG India index, if anyone of you are aware of that. I hope all of you are. The SDG 3 India index, we have topped over the past 2 rounds. But interestingly, it does not include the nutrition indicators. That goes into SDG 2. And that's why we've been able to, kind of say that, Gujarat is at the forefront of health and development, but we need a reality check. So with that thing in mind, we all know that, we had CNSS surveys which gave us some findings. We have NFHS which has given us very poor findings. So the state decided that why not do something on our own, have a good sample size, and try and figure out, what's actually happening on the field. How much anemia are we looking at, and what are the possible determinants of that? So with that, we collaborated with IIPHG in order to undertake this assessment, and the presentation is going to briefly touch up upon what are the various aspects. I'm not going into various details because I'm sure all of learned people here are very well aware of what has been, and it has been amply discussed in various public forums. So I'm not going to go into why, what, we all know. Just few pointers which we need to see is as compared to the trends in India on the left side, the central graph shows that we are doing much poorer as the rest of the India. In fact, the IFA distribution is also bad. I mean, if anybody is there from the public service or public health division, they will accept that the supply is a big issue. But hopefully the state is trying to sort that out. We are not no longer depending on the government of India supply, and we are trying to ensure that, you know, the 100% procurement comes from GMSCL, so that we are able to ensure that there is a continuous supply. So if you see, pregnant women IFA was given because, you know, we are getting good supply from the government of India, but when it was coming to adolescent and children, even the IFAs were a little short in supply. I think this graph, basically what I would like to show you is, look at the extreme left and extreme right. The extreme left shows us what we were at 99, 98 in NFHS 2, and the extreme right is NFHS 5. So we've just worsened as the time has grown, and this is a life cycle issue. So this, we are talking about anemias in children 6 to 59 months, adolescent girls, non-pregnant and pregnant women. So the situation has not improved. In the fact, it has deteriorated. A desegregated age-wise analysis shows that, you know, the anemia has gone up, especially more amongst the adolescent girls. This is for the women of reproductive age. When you're talking of how anemia has changed between the various NFHS rounds, we see that while overall anemia has slightly increased, I'll just a disclaimer, this is the slide for India. The findings are very similar to Gujarat, but even poorer. So what we've seen is, while all types of anemia has increased, mild anemia has decreased, and the shift is towards moderate and increase in the moderate and severe anemia. And this is something that should be alarming, and we should be really careful about that, because, you know, mild anemia is something which is very easy to correct. But when you're going into moderate and then going further into severe anemia, that is something which shows that something is fundamentally wrong with what we are doing. I mean, in spite of doing something continuously for so many years, we need to rethink where we are going wrong. A few facts already published, very well known. I'm not going into the details of that. It's just that alongside anemia or iron deficiency, so we are the third highest prevalent iron deficiency state in the country. So we are the only state which has more than 33% of iron deficiency as well as anemias. And I think subsequently Dr. Shalu will go in depth with various aspects of this. I'm not touching into that, but this is something that we are highlighting. And I think the studies also tells that, you know, not every anemia is iron deficiency anemia. However, iron deficiency continues to play a significant role. This is few of the districts. You know, normally what happens, you know, when we are saying that we are eliminating a particular disease or we are tackling a particular problem, we see that the state average might be high, but there would be many districts which would have attained a particular target. What this graph shows, that most of the districts, the level of anemia is exceedingly high. So I think, and from the public health point of view, any prevalence more than 40% is considered to be a public health problem. So there are several of the districts in which we are having severe issues as far as anemia is concerned. This is for the women of reproductive age group. At this juncture, I'll just take a moment to talk about some of the newer initiatives that the government of Gujarat has undertaken. We are going to restrict myself to the Health and Family Welfare Department since we are from there. So I think some of these have been approved, some of these are being planned, some of these are in the process of being proposed for further. First of all is the multiple micronutrient supplementation to pregnant women. So the Health and Family Welfare Department is going to roll out this pilot initiative across 60,000 pregnant women. So what we are going to do is we are going to provide them MMS supplementation along with IFA for about 6 months, 180 days. So this has already been approved. Next is the Poshan Sudha Yojana. This Poshan Sudha Yojana, under that, this is already happening. It's already rolled out in the tribal districts. As part of the Poshan Sudha Yojana, cooked meals are given to pregnant women. I think to pregnant as well as postnatal women, they are giving cooked meals. So what the health department has done is it's providing some financial support to the WCD department in order to augment the I would say the nutritional component of that particular meal that they are giving. So we have recommended that there could be millets, there could be other legumes, and some dietary diversity that could be provided. So that is something that has been planned. Next is protein supplementation to pregnant women. So again, this is going to be undertaken on a pilot basis in 25 blocks in which the low weight pregnant women, the prevalence of low weight pregnant women, that is less than 45 kgs, is high. So we've identified 25 blocks, and across these blocks they will be given protein powder, which is roughly about 12 grams of protein supplementation along with 120 kilocalories. That will be given for about 6 months. What is currently on the proposal stage is one is fortified cookies. We're calling it cookies here, but we're talking in terms of it could be a ladvo, as we say, or something which is nutritious, a fortified aspect, which will be given to the high risk pregnant women across the state. We've also written to the education department and requesting them that, as well as that if they can also provide something similar to the children, and requesting that, for the MDMs, at least introduce breakfast as part of their MDM, the midday meal scheme. Because what happens is in the rural areas and in a lot of other less privileged homes, breakfast, which happens to be one of the most important meals for the day, is often missed. So that is one recommendation that has been gone to the department, and we've offered that, in case health department can offer any assistance, we would be happy to help them out. Apart from that, we are also planning to pilot iron ascorbate. So instead of the ferrous sulfate, we would be going for the ferrous ascorbate salt, and we are hoping that it can help improve the take up of IFA, which we've seen that often the consumption is not so good. Alongside, we've taken a statewide assessment for anemia profiling. So we started with 5 districts. So the current presentation, Dr. Chalu is going to go through the findings of that particular 5 districts. But alongside, currently we are having this anemia profiling study on in further other 10 districts. I've just mentioned the districts for your reference. I'm not going to go into that. It basically covers all sorts of geographies, urban areas, rural areas, all regions, tribal aspects, rural aspects, all those things. We've tried to cover comprehensively the entire state. So the current study that we are going to talk about was undertaken in 5 districts, including 1 corporation. That's the Ahmedabad Municipal Corporation, Banaskantha, Junagadh, Valsad and Kutch. So what we did is, across all these 5 districts, we took 3 PHCs or urban PHCs, and in that, ultimately, we took a total sample size of 1500. So 300 per district and subsequently 100 per PHC, and that 50 adolescent girls and 50 pregnant mothers. So that is how the study was conducted. It was a cross-sectional study. What we did is we had a socio-demographic tool which asked basic information, demographic aspect. We also had some nutritional information being undertaken. Along with that, we had also wash parameters which were assessed. So at the end of it, the whole objective was to find out, what is the prevalence of anemia, and also to identify what are the possible determinants of that. So, in a nutshell, this is what the finding is. We have about 44.3% anemia, which is seen amongst pregnant women, and 39.6% anemia, which is seen in the adolescent girls. To the right, you can see that we have compared it with what NFHS 5 has said. So, only thing to be remembered here is that, while comparing various findings, we need to remember how the HB estimation was done. The NFHS uses the HemoQ, the capillary blood, whereas the CNNS and the current study had the venous blood sampling which was done. And we also had a lot of micronutrient tests also incorporated into the entire assessment. I'll request Dr. Shalu to please take the further findings. Thank you so much.
Thank you, Harsh. Did a good job.
Thank you, Dr. Harsh, for setting up a very good context as to why this study was undertaken. As Dr. Harsh said, the prevalence of anemia which we found among pregnant and adolescents was at least 2/5 of the adolescent and pregnant were found anemic. Now this was a little different from what we have seen from NFHS 5 data sets, but then again if we look at the SDG 2 targets, I think Dr. Harsh mentioned that SDG 3 does not have nutrition indicators included. So when we look at these indicators, we are performing a little poorer, and to achieve the targets of 50% reduction of anemia among pregnant and adolescents, which follows the WHO global nutrition targets, we are short of 19.1% in pregnant women and 25.4% in adolescent girls. So it is a huge public health problem for us. When we further describe the anemia among these two groups, we found that when we looked at the socio-demographic determinants, we did not see any major differences, be it geography, schooling, adolescence period, or literacy and trimester and parity among pregnant women. And so to say that when it comes to dealing with anemia, everyone across the life cycle must be considered in the high-risk group. Further, in the study, we tried to understand more deeply as to what is causing anemia. The broad classification which we use is whether we have iron deficiency anemia or non-iron deficiency anemia. Now, we used ferritin cutoff of less than 30 microgram per liter to see whether there is iron deficiency, which is, that is why anemia is there. So if we see these two bars, we see that we found that there was a similar prevalence in adolescent and pregnant women. And surprisingly, only 23% had no detected abnormality. When we compare, so similar estimates were given by CNNS survey as well. And when we compare it to CNNS, the apparent iron deficiency, which we see in the blue and the red bar. So apparent iron deficiency was 70% in our study, while in CNNS it was 21.5%. The blue portion, which is no anemia and iron deficiency, we see it as a window of opportunity because they are currently not anemic, but they are iron deficient, and if not addressed, they can shift to the red portion. And that is why it is a window of opportunity. So if we address, we prevent at this point, they will not shift to the anemia and iron deficiency group. So what we feel is that the Anemia Mukh Bharat talks about the T3 camp, a very popular strategy which says that test, treat, and talk. But what we feel is that a very major strategy which can come here is that talk should be, a mainstay. Talk should be there at each and every point. So, talk, test, treat, and prevent, and track. So, tracking each and every individual, whether anemic or non-anemic, and talk can be a probable mainstay strategy. Now, as we saw that there was a huge burden of non-iron deficiency anemia. So we looked at the iron profile of anemic adolescent girls and pregnant women. Ferritin, so it indicates that it is basically the indicator of the iron stores in the body. So we look it as the savings account in the bank. Now, that was low in 81% in adolescent and 76% in pregnant women. This indicates that there is iron deficiency. The stores are deficient. Now, if we look at serum iron, which indicates circulating iron, so basically the cash which you have in your pocket, it was low in 53% of adolescents and 48% of pregnant women, which shows that there were depleted stores, and now circulating iron is also less. The total iron binding capacity is the capacity of transferrin to bind with the iron, which generally increases with iron deficiency. We found that it was high only in 8% adolescent girls and 32% of pregnant women. So if you then so it raises a question that what is causing this anemia? Now, if you look at the transferrin saturation, it basically is the ratio of TIBC and serum iron. The T saturation levels indicate the iron deficiency, and along with it, the inflammatory and other nutritional deficiencies as well. And we found that 67% of anemic adolescent girls and 65% of anemic pregnant women had low transferrin saturation. When we look at low transferrin saturation along with low ferritin levels, we can identify how many individuals have absolute iron deficiency. And it was surprising to see that 37% of adolescent girls and 44% of pregnant women had no absolute iron deficiency anemia. Now, we did binomial logistic regression, and we found that the positive effects of having odds of non-iron iron deficiency anemia was seen with HbA1c, ESR, serum zinc, and vitamin D levels. And that was similar in adolescent as well as pregnant women. We found inverse effect with folate and vitamin A, and no significant effect with CRP and vitamin B12 levels. Now, so as to say, now most of them, the odds are very close to 1, but HbA1c, the odds was higher, 5.4% in adolescent girls and 2.88% in pregnant women. So glycated hemoglobin can cause non-iron deficiency anemia is something which was very interesting for us, and as Monica ma'am also talked about syndemic approach. So such similar things, complicated things, we are also finding from data from our preliminary analysis. So we looked at the micronutrient deficiency in overall all adolescent and pregnant women, and we found that 92% of adolescents were vitamin D deficient, followed by 35, the second most common deficiency was vitamin B12, which was 35.9%. Similar pattern was seen in pregnant women, but the second most common vitamin deficiency which we found was zinc deficiency. So this was something which was alarming. And if we see at the prevalence trimester wise, the deficiency of zinc increases as the trimester progresses. So childbearing probably has, causes zinc deficiency, that is also what we, I think, need to keep in mind. So to sum up the entire presentations, I have 7 key takeaways. So anemia is a significant public health problem, and reduction of 19.1% in pregnant women and 25.4% in adolescent girls is required to achieve SDG 2 for Gujarat. Only 23% adolescent girls and pregnant women have no detected abnormality. The window of opportunity in 38% adolescent girls and 32% pregnant women with iron deficiency but no anemia must be addressed to prevent their transitioning to IDA. So I have mentioned talk on the both ends. So talk has to be the mainstay of the strategy, and testing everyone, treating the iron deficiency anemia, preventing those who are found normal on the test, and then monitoring everyone probably is the mainstay strategy. 37% anemic adolescent girls and 44% anemic pregnant women do not have absolute iron deficiency anemia. Now under Anemia Mukt Bharat, till now we have just talked about giving iron folic acid and have not, so what we see that we are still not addressing this 37% and 44% of adolescent girls and pregnant women. We are actually missing them. And in our preliminary analysis, we found that underlying micronutrient deficiency and inflammation is the causative factor, and HbA1c has also emerged as a significant factor. Zinc deficiency in pregnant women is concerning, and we need to gather for evidence generation and synthesis. Vitamin D deficiency again is a serious problem which affects almost everyone. Multiple micronutrient supplementation, which is an essential nutrition action given by UNICEF, UNDP and FAO, must also be explored. And well, I end this talk, I also want to reiterate that, this is, I think Madam also mentioned in her inaugural talk that what we are trying to address, the end is lying somewhere else, and probably this has several ends, and it is more complicated than we ever thought. So, thank you everyone. Thank you for patiently listening to me.
Based on my experience, one is we ultimately at peripheral level, our ANMs or now ASHA are going to distribute tablets and motivate mothers to take it. Okay. And I remember when I was moving from district to district for IMNCI program, I asked ANM supervisors, who were around 200 in every batch, how many of you during pregnancy have consumed 100 tablets? And 10 hands will raise. So, આપણા આવા બેટેલિયન સાથે આવા લશ્કર સાથે બેટેલિયનમાં લડવાનું છે. So keep that in mind. 50 વર્ષથી 40% બહેનો ગોળી ખાય છે એવું ભણાવું છું. And it has not changed. And we are talking about giving more and more tablets and drugs, which probably I don't know how much it will work and how the system will cope up. Okay, second thing is, this is for the researchers to keep in mind. I was taught again in 74-75 that if you correct the anemia in mother, the storage of the child fetus will be better, will improve. Otherwise, anemic mother, the child will be born with normal hemoglobin but will have very poor storage. Now in that situation, how are we going to improve the storage if we don't focus on mother? So that's how there is a priority to focus on mother and do it. The third thing is, which I am very fond of, there are traditional practices which are not harmful. We are not thinking about that and giving some other supplements to the group, considering that as a nutritious food. Fenugreek laddu from 7th month of pregnancy, which is rich in iron, calcium, calorie, protein, all supplements are given to the mother, and we don't know about the magnesium and other things, but maybe there. And gum acacia laddu, gundarna laddu after delivery. Are we taking enough care of mother after delivery? No. And we are not preparing her for next pregnancy, or we are not even taking care of her nutrition so that she can look after the newborn baby well. Education, love, and nutrition. So we do need a program which is 1,000 days program for pregnant and postnatal mothers also. It's not only for baby. Whenever I have asked to the people who are working in the system, they say, postnatal care करते हैं ना? क्या करते हैं? 10 दिन के विजिट फॉलो अप जो होती होगी, जो उनको पता, उसमें न्यूट्रिशन नहीं आता है, फीवर आता है, ब्लीडिंग होता है, बस उतना पूछना है. That is not enough. So please develop a protocol for postnatal mother care. She accompanies the baby for Mamta Divas or whatever Divas you call it, and there is a scope to not to miss, to weigh her at 3 months interval, to guide her, to assess her for hemoglobin, and to take care of her. If this is not happening, then any amount of policy will not work in correction of the problem. Adding more tablets, adding more food is not the solution of malnutrition care. That's what I have learned in all these years. So this is just an addition to your thought process, what you are working on. Your findings are very valid, but when you think in terms of action, please think in terms of who is going to work, whether she will be able to work or not, whether it will be effective or not. I remember even iron tablets supply was a problem, but we used to get 90% distribution to mother. And when I asked, they said it was in pipeline. We have a long pipelines of supply. Okay, so people know how to report, how to look at it. So we should know how to advocate for policy and work for it. But with that, it is a wonderful subject to work on. We can make a dent on it. We can improve. There is one more observation. If you look at NFHS 4, non-pregnant mothers are more anemic than pregnant mothers. Is it that they are not getting enough iron folic acid afterwards in time? It is reproductive age group. So consider these factors also. We can make an impact on it and look at it as a holistic issue up to supply chain and up to consumption chain, not only as the advocacy for intervention. Thank you with that. Thanks to all.
I'll justify my existence here as adolescent pediatrician. Please note that the anemia was equal, almost equal in pregnancy and adolescent girls. So don't blame it on menstruation. Most people do it. So don't do that. That does not lead to anemia, one. Second, it's a relative state of deficiency. If you understand that, then you will realize why it is so common between two, pregnancy and adolescent girls. Because both are relative state of deficiency, wherein one, the demands come from the baby, and in another, the demand comes from her own growth and development. So keep this in mind. And the third question I have, or third suggestion for Madam wants to know that how many of you have a hemoglobin of less than 11 gram? This question is very pertinent because I tell my students, of course, please don't record, that we have already added 2 Eiffel Tower worth iron in the state of Gujarat, and still we are dealing with anemia. So there is something wrong somewhere, and that is why the question. How many of you have 11 grams and more percentage hemoglobin? In this august body, 70%. So the researchers have to try and find an answer whether we are dealing with the norms which are not meant for us. That has been my hunch. Harsh knows it well. And we have debated on it. And I want some sincere research, vertical data on establishing what is the norm for Indian population. We are accepted from somewhere 14 to 18 and 12 to 15 and then working with it for all these 75 years. Are we doing the right thing, or we need to have our own norms? That is the fundamental question raised because, as I told you, anemia has become a kamadhenu for all of us. Work for it, be funded, produce some data, debate it, and again reinvent the wheel.
And my last word is, please try to find out non-invasive method of measuring hemoglobin. As a public health person, we don't need point something as a result. What we need is cutoff, less than 9 gram, 9 to 11 gram, 11 to 12, which will be enough. But in case of children, we are making more errors in estimating hemoglobin in laboratory by prick. Any method, HemoQ or whatever it is, because prick is not adequate for children, and that's why they press it, and then there is a dilution, and we give wrong results for it. So if we can measure nowadays uric acid with a non-invasive method, if we can measure blood pressure with non-invasive method, if we can measure blood sugar with non-invasive method, why not hemoglobin? And don't think about error of point something. That in public health is okay if your problem is 60% and 40%.
Thank you, madam.
What an engaging deliberation. This could not have been done in a better way than here. The participants have had good insights to carry back with them. We would request the chairs to felicitate the speakers of the plenary. Dr. Raj Shankar Ghosh, Senior Advisor, Center for Environmental Health, PHFI. Professor Monica Arora, Vice President, Research and Health Promotion Division, PHFI. Dr. Harsh Bakshi, Team Lead, SHSRC, Gujarat. Dr. Shalu Chaudhary, Assistant Professor, IIPHG.
I would now like to request Dr. Sandhu Yashoban to felicitate our chair, Dr. Vikas K. Desai.
I would now request Dr. Sumen Saha to felicitate Chair Dr. R. Bakshi. Thank you, everyone. We would request a group photograph for the speakers of the plenary. As we gather here, let us also take a moment to appreciate the tremendous support and hard work put forth by the organizing committee and volunteers who have worked tirelessly to make this event possible. Their commitment ensures that we have a seamless and enriching experience. Let's continue cheering each other with a loud round of applause. At this time, I would request the judges and chairperson of oral and poster presentation to be there in the respective venues.
The conference is a right place for exchanging our ideas, presenting them, and exploring the future collaboration opportunities. The scientific sessions with poster presentations are scheduled right now across the campus at different locations. These are displayed on the standees in the foyer area. There are 4 sessions for oral and 3 for poster. Let us proceed towards the scientific presentation areas. We will be back at 5 p.m. here at the amphitheater for the quiz, which will be by the IAPSM GC activity.